Good morning, everyone. So, we'll begin with retinitis pigmentosa today. So, as the name suggests, it is a retinal dystrophy, right? And it's an hereditary disorder. And what is important is that rods are more affected than cones. Okay, so it's a dystrophy of rods is present, but later cones are also involved. Now, coming to this inheritance pattern. So, as we know, that it is an hereditary disorder, so obviously it will be like sporadic and again inherited. So 40 to 50% cases are sporadic and the rest are inherited, right? Inherited, most common, what you need to remember, that they inherit as autosomal dominant disorder. Some may also inherit as autosomal recessive or X-linked recessive, but which is very least common. But autosomal dominant is seen in around 15 to 25% people. Now coming to its prevalence, so it is prevalent in around 1 person per 5,000 of the world population. So this is its prevalence. So how does it occur? See, it appears in the first, it will appear in the childhood, right? And so it will progress slowly, and then often in the middle age it will result in blindness. So it's a progressive degenerative condition, right? Coming to the sex, so it is more common in females as compared to males, around 3:2 pattern. And see, almost all degenerative conditions, they occur bilaterally, so it is also a bilateral condition. So how does it happen? See, it's a very big puzzle, because we haven't a concrete hypothesis over it, but we know that there are death of rod photoreceptors. And how does it happen? By apoptosis, right? But later we know that cone cells, they also start dying. Okay, so ultimately they also die from the disease. So again there will be blindness in later years. Now coming to its, see, on the relative involvement of rods and cones, we divided this into two categories. See, it was type 1 retinitis pigmentosa or type 2. So what is type 1? See, type 1, it's an early and preferential loss of what? Loss of rod sensitivity. Okay? So if the rods are involved, then the main clinical feature will be its diminished night vision, because rods are meant for scotopic vision. Then progressively again it can cause complete visual loss. Now in type 2, they have a progressive, and important thing is it is in combined dystrophy, so both rods and cones are affected. Okay? So first though there will be, both will be affected, and later on diminished vision will be seen. It will not be the first feature. So we know something about the pathogenesis. Now coming to its clinical features. So first is, what will be the visual symptoms seen? Very obvious, night blindness, obviously. And second is dark adaptation. Actually, it has been seen that the light threshold for the peripheral retina is decreased or increased. Obviously it is increased. So if the threshold is increased, so there will be difficulty in peripheral vision, right? Coming to tubular vision. So again I told you that periphery is more commonly involved, so there will be a tubular vision seen. After many years, central vision may be also lost, and in some people they may have photopsia, that is flashes of lights are seen. So these are the visual changes. Now what are the fundal changes you will see? Very obvious, retinal pigmentary changes will be seen. तो क्या होगा उसमें? There will be perivascular. See, around the vessels there will be changes, and there will be jet black spots which will resemble bone corpuscles in shape. Initially these changes are found in the equatorial region only, and later they will spread both anteriorly and posteriorly. So suppose this is your eyeball, so this is the equator. So firstly they will be present only in the equatorial regions. These changes are around the vessels. Okay, suppose this is the vessel, so changes are around the vessels. So these are perivascular changes, and there will be jet black spots will be also seen. So this is the picture I was talking about. So as you can see, there are, what are these? These are jet black spots which are seen, and they do resemble like as a bone corpuscles in shape. So they are first present in the equatorial region, later anteriorly and posteriorly. Then you will find that retinal arterioles, these are attenuated. Means attenuation means they are narrowed. Okay. So later they may become like a thin thread like. Then there will be thinning and atrophy of what? Retinal pigment epithelium. Okay. Optic disc will be pale and waxy. Why? Because in later stages optic atrophy may occur. Then coming to the visual field changes. So what do we find in visual changes? In visual field, there will be scotoma will be present. Okay. And I told you that initially peripheral vision is more affected, and then later on they will increase, these scotomas will increase, and only a tubular vision will be left, and later on the person may go blind. Then coming to the electrophysiological changes. See, electrophysiological studies are a mainstay in such conditions, right? So we do two tests, ERG and EOG, that is electroretinogram and electrooculogram. So what are these tests? See, in electroretinogram, in a normal person, we see three waves are there, right? It is something like this. Suppose this is your baseline. So this is your A wave, this is B wave, and this is C wave. So what are we measuring? We are measuring the retinal pigment potential. Like what is the change in potential is seen by a flash of light. Okay, and the person is laid supine, and then we test for this. Okay, so there is a flash of light, and we'll see what is the difference in the potential is seen. So A. So firstly, as you know, the first cells to get stimulated in retina will be your photoreceptors like rods and cones, and then later bipolar cells. These are the second order neuron, and at last, what are these? These will be your retinal pigment epithelium, right? So basically we'll see this. So there is a degeneration, right? So there will be decreased or subnormal potential which will be seen in ERG in case of retinitis pigmentosa. In case of EOG also, so in EOG what will be there? Electrooculogram is there. We basically check about the cornea and macular retinitis रेटिनल रेस्टिंग पोटेंशियल का डिफरेंस हम देखते हैं इन इलेक्ट्रोओकुलर सो इट विल बी ऑल्सो सब नॉर्मल. So what we basically measure is like we measure the Ardens ratio, okay, and it's a ratio obviously. So there will be spikes will be seen whenever we give light, right? And these spikes, when we give the maximum light divided by the spikes which are given, which comes actually on minimum light into 100. So this comes out to be your Ardens ratio. So if it is more than 185, then we say that it is normal. If it is between 150 to 180, then we say it is borderline, okay? And if it is 150 se less, so it is subnormal. So this is the subnormal finding is seen in retinitis pigmentosa, and if it is less than 125, then obviously it is flat, and so less than 150 is the finding of EOG as seen in retinitis pigmentosa. Okay, now what are the associations of retinitis pigmentosa? So association means first to ocularly along with RP, what else will be seen? So there could be myopia, there could be open angle glaucoma, right? There could be keratoconus. Second, what are the systemic associations? So most cases they are isolated, mostly means there is no systemic illness, and such cases हम क्या कहेंगे? We'll say them as retinitis pigmentosa non-syndromic, there is no syndrome, or as simple retinitis pigmentosa. Am I clear? Now there will be other cases about 25%. As I told you, most cases they are non-syndromic, but 25% will be syndromic. So syndromic RPE, retinitis pigmentosa. So they are first. So the syndromes are important. MCQs might be asked. First is Lawrence Moon Biddle syndrome. Okay, so what is seen in this? So you can remember it by this mnemonic OGPM. Okay, so obviously we're talking about retinitis pigmentosa. So retinitis pigmentosa will be seen. For O, there will be obesity. G for hypogenitalism. P for polydactyly. And M for mental deficiency. Cool. Then coming to the second syndrome, that is Cockayans syndrome. So with C, you can remember it will have cerebellar features like ataxia and nystagmus. Along with that, deafness will be seen. Dwarfism. So after C, there comes D. So deafness and dwarfism. And obviously retinitis pigmentosa. Coming to the third, that is the Refsum's disease. So Refsum, it has progressive peripheral neuropathy along with cerebellar ataxia. Okay. So now coming to fourth, that is Usher's syndrome. See, in Usher's, Usher's, when you that means you want it to be less. So you want to be deaf basically. That is a very bad mnemonic, but just learn it. So along with retinitis pigmentosa, obviously there will be deafness will be seen. So we divide these into three types: type 1, type 2 and type 3. So if there is deafness, okay, see, पहले तो we'll divide it like deafness. So profound deafness, then उससे कम there will be moderate to severe deafness, and maybe there is means progressive hearing loss is there but not severe. ठीक है. So first is deafness. Second क्या हो गया? Second will be your ERG. तो पहले में क्या होगा कि first decade में ही आपका जो ERG है that will be the potential will be very less. Second, what can happen in type 2, second decade में there will be visual loss, and in type 3 जो आपकी main that these pigmentary retinopathy changes they occur very late. So like after second decade there will be changes in the retina, or the retinal pigmentary changes are very delayed in type 3 Usher's syndrome. So last syndrome is Holmgren syndrome. So if somebody like shouts like "oh," right? So what happens is suddenly you become deaf. So there can be congenital deafness, and again you might fall. So that will be vestibulocerebellar ataxia will be present, and okay, mental deficiency can also be seen. So mental deficiency is seen in mostly disorders, right? So these are all the syndromes associated with it. There is one other thing, that is what are the atypical forms. So what do we mean by atypical? So typically there is a presence of rod dystrophy. So if it is other than that, or maybe cones are more involved, if there is no rod dystrophy, so that we say that these are atypical cases. Like first is retinitis pigmentosa sign pigmenta. Now the name suggests that there will be some problem in the pigmentary changes. So there is no pigmentary changes seen in the fundus. Coming to sectorial means obviously a particular sector is involved. So only one sector is involved. Pericentric retinitis pigmentosa, again one particular area is involved. Then retinitis punctata albicans means there will be white spots which will be seen, as albicans is white, punctate spots are seen. Okay, so these are the atypical features. Coming to treatment. So as of now there is no treatment of retinitis pigmentosa. So what are the measures? So you cannot treat it, but you can stop the progression. So there is some benefit from vasodilators, or some rectus muscles are transplanted. So there is like these are important. Recently we see that vitamin A can be used for seeing checking the progression. Acetazolamide can be given. So acetazolamide is an ACE inhibitor, so it can be given if it is associated with some CME is present, or that. Stem cell therapy, like vision aids can be used at night, right? So magnifying glasses can be used, or rehabilitation. Okay. For prophylaxis, now you know that you cannot prevent this, but obviously there is one thing. See, this is an, I told you the inheritance is there. It is autosomal dominant or autosomal recessive or X-linked recessive. So if there is no consanguineous marriage, like if you ask, like if there is genetic counseling for consanguineous marriages, you may help to prevent this condition.